Hello everyone, this is DrSotalol. Today we are going to talk about the diagnostic evaluation and clinical approach and some of the differential diagnoses of COPD exacerbation. As a disclaimer, this video is not any kind of medical advice, but just good old medical education. So, first of all, maybe we should mention quickly about diagnostic definition of COPD exacerbation. We mentioned it a little bit in the previous video where we explained the clinical features and physical examination of the COPD exacerbation, and it is really good to remind ourselves what exactly is COPD exacerbation and what are the most important definitive components of it. So first of all, there are a couple of different definitions which are basically more or less the same, and each of them usually includes worsening of the symptoms from their day-to-day variation. So COPD patients have day-to-day variations. Sometimes they have a little bit more dyspnea. Sometimes they can breathe a little bit better, but this is the day-to-day variation. But an exacerbation may be a possibility if the patient is really much more dyspneic than the several past weeks. So worsening of symptoms from day-to-day variations. The second one is about the dyspnea. So this is the in general worsening symptoms, and the second one is dyspnea plus sputum production change. So dyspnea increases and sputum production increases. Sometimes the definitions include sputum characteristic or sputum quality change. For example, now it is more thick mucus or the color change, but in general, more sputum production and more dyspnea. And the third one is, in the end, it will be a true COPD exacerbation if the patient's medication schedule is changed. For example, you add an inhaled corticosteroid in the end, because we don't want these COPD exacerbations to happen to COPD patients. Therefore, if this is a major exacerbation, his medications will be changed. So switched meds. So these are the three more or less cardinal things in the definition of COPD exacerbation. Now, let's talk about which tests and which imaging modalities should we obtain in those patients. So, first of all, we have to check the vitals as always. Is the patient hemodynamically stable? Is the patient requiring really immediate medical attention? Is the patient should just directly get intubated in the ICU, or should we perform CPR even if the patient's vitals are quickly decreasing? So look for the SpO2, the pulse oxygen saturation, BP, fever, and heart rate. 2. Get an EKG. EKG is very important in these patients because these patients may present with dyspnea, and maybe in a COPD patient, the physician would think, okay, the exacerbation is the primary diagnosis possibility. However, an acute coronary syndrome also may present with a dyspnea. And dyspnea, especially in elder patients, sometimes much more evident than chest pain, especially in ladies, especially in diabetic patients, and especially in elder age. So these three, elder age, older patients, diabetes, and females. So look out that these three groups may present with atypical acute coronary syndrome symptoms. So look out for them. For example, nausea. For example, perspiration, sweating. For example, dyspnea. Even lightheadedness, there are some patients who present with. So this is really important. So obtain an EKG, of course, together with cardiac enzymes. This is really important. And after that, EKG should also be evaluated for any kinds of cardiac arrhythmias, because the COPD patients may undergo dyspnea if they have, for example, new onset supraventricular tachycardia, such as atrial fibrillation or flutter. So also, the cardiac arrhythmias is a really important differential diagnosis in a patient, in a COPD patient who presents with dyspnea. So look out for that too. So EKG is really important. Sorry that I cannot use the board really well as the space. I cannot manage its space really well, so I have to clear it now. So what did we, the vitals, the first one was vitals, EKG, cardiac enzymes. Okay, the cardiac enzymes I wanted to mention because they come in together with EKG. However, just obtain the vitals and EKG, and we should more or less, after the bloods are drawn, or even before, we should send the patient for chest X-ray. This is the cornerstone thing that we should do in a patient who presents with dyspnea. All the patients present with dyspnea should undergo chest X-ray. This gives really golden clues about some of the really important differential diagnoses in this patient, such as pneumothorax, such as pneumonia, such as pleural effusion. Even acute coronary syndrome may be evaluated with a chest X-ray, such as sometimes there is a really decompensated cardiac failure, so the patient undergoes pulmonary edema. Therefore, all the dyspnea patients should undergo a chest X-ray, and it should be evaluated right away. And if it doesn't require immediate medical attention, we can continue with the other tests too. Okay. So the other tests are usually such as the arterial blood gas. This is really important in COPD patients because arterial blood gas can show us that if the patient is in acute or chronic respiratory acidosis. This is really important because if the patient is in acute respiratory acidosis, this means he or she is going to be intubated because their respiratory muscles start to lose their strength, and now they need ventilatory support to be oxygenated. But sometimes the patients are in chronic respiratory acidosis, and this is more easily manageable than acute because COPD patients sometimes do not adhere with their medication schedule, and normally if a healthy person has oxygen saturation less than 95 or 90 even, they will experience symptoms, for example, lightheadedness, malaise, vertigo, blurry eyes. However, these COPD patients, they change their body, their body changes to tolerate hypercapnia. So therefore, and this is a really important and actually controversial thing, but usually the mainstay procedure is that we try to put these COPD patient oxygen saturation between 88 to 92%. We do not want this to go up or go lower than 88, but it shouldn't also go upper than 92. But this is also a controversial topic that we may create another video for that. So sometimes a patient will come with 70% of blood oxygen saturation, but in the chronic respiratory acidosis, if the ABG shows it, then it is probably like this for a long time, maybe 75%. But these patients are able to tolerate it pretty well, even for months. And of course, we should also now talk about some of the other lab tests that we should try to evaluate. Okay, so this topic is a little bit controversial, but we will start from the least controversial one, labs. So complete blood count with differentials. This is important for two aspects mostly. First one is we are looking for any kind of leukocytosis or increased eosinophils. So we are looking to a leukocytosis table if the patient is having a bacterial or viral COPD exacerbation. And pretty much there are three reasons that we talked about the COPD. So the first one is the bacteria, the second one is viral, and the third one is inflammation or eosinophils. So it is really important to look for those two. And there are some studies, so in the management aspect, some of the studies looked for eosinophil count to initiate systemic steroids or not. So they found that in patients with really little elevation of eosinophils or no elevation, the systemic steroids didn't work very well. But in patients who have high eosinophils, systemic steroids worked much better. It is not a definitive management aspect, however, it can give us a clue about it. So therefore, I suggest we should look at especially those two. The second one is, of course, electrolytes and also BUN, creatinine, so the renal function tests. So, okay, these are pretty straightforward. But what I want to talk about it is a bit of a controversial aspect, which is C-reactive protein and procalcitonin. Even up-to-date does not suggest or does not suggest C-reactive protein measurement. They specifically say we do not use procalcitonin or C-reactive protein to determine the need for antibiotics in COPD exacerbations, as study results do not clearly and consistently demonstrate that either assay adds value to clinical judgment alone. So, of course, the studies may not show that it adds something to the clinical judgment. However, if we can obtain those two, in my clinical practice, I tend to obtain them. It is not a must that we shouldn't obtain it, so it doesn't give harm to the patient. But it just suggests, the current literature suggests that we should not base our diagnosis and antibiotic management solely, only on those two things. So we tend to give those two parameters, those two assays, much more importance than we should give. So the main idea is you may measure those two. We may see if the patient has elevated CRP or procalcitonin, but we shouldn't take it too seriously. It will just be a clinical helpful hand for us. And another thing that may be a good thing is that if we measure a person's procalcitonin, then if we are thinking that we are going to initiate some antibiotics, after 3 or 4 days, if the patient doesn't getting better, then we can measure it again to see for the treatment response. It will help like that too. Same goes for the C-reactive protein also. And the other two, the NT-proBNP or just BNP, this is relatively clinically helpful because heart failure can also produce dyspnea in any patient, especially in COPD patients, where their lung capacity isn't really high. Therefore, of course, total lung capacity is high, but I wasn't mentioning. So, if a patient did not have any kind of heart failure diagnosis before, and we see that the NT-proBNP or PNP is elevated, that means we should do an echocardiography and probably obtain a cardiology consultation to be safe. And the last one is D-dimer. D-dimer is also a really controversial thing. Most emergency physicians do not like D-dimer, because if it is elevated, you cannot discharge the patient, more or less. So D-dimer why is it important in these types of patients? Because a very important differential diagnosis is pulmonary embolism in patients with COPD who present with dyspnea. So we have some scales, the Wells scoring table, Wells score, pulmonary embolism rule-out criteria, PERT score. So probably it is a really good and safe way to obtain the Wells score of the patient, and if the patient is less than 50 years old, of course, and probably in a low probability situation, we can obtain PERT score, and we can go from there. We can follow the pulmonary embolism algorithm, and if we have really big clinical suspicion, we may also obtain the CT pulmonary angiography. But if the patient has relatively low Wells score, for example 2, and the D-dimer is normal, then it is not a really good idea to obtain this angiography. So I suggest you follow the current algorithms. But always keep in mind that any COPD patient who present with worsening dyspnea that is much more than their day-to-day variation should be evaluated for pulmonary embolism also. And of course, the respiratory virus panels. So if your hospital, if your facility is able to do it, I suggest you can also get respiratory virus panels to see RSV or a possible other infection. And also these days, COVID-19 test is also really, really important, and it is warranted. So these are the most common things that we should do at first, and then we can go from there. So, and the final thing that I want to tell you about is the differential diagnosis. I'm not going to tell a really big, I'm not going to give a really big speech about it, but I feel that we talked about it more or less in the previous video and this video, but I'm also going to mention a few really important diagnoses. So the most important differentials are, as we mentioned today, congestive heart failure. So what did we do for that? We obtained NT-proBNP. And if we have really clinical suspicion or this is elevated, we may have echocardiography. Or if the patient undergoes computed tomography, we can also see if there is any pericardial effusion or pleural effusion. Cardiac arrhythmias, what did we do? We obtained EKG. Coronary artery disease or acute coronary syndrome, what did we do? We obtained ECG and we obtained cardiac enzymes. Pneumonia, what did we do for that? We obtained the chest x-ray. Pneumothorax also can be ruled out with the chest x-ray. Pulmonary embolism, this is really important. And what did we do? We we did our Wells score, or if the patient is in low probability situation and less than 50 years old, we did the PERT score. For example, PERT score is 0, we can safely rule out this. And these are the most important ones that we should think about. So there's a study that I want to mention the final words. There was a study in 2009 in the really prestigious chest journal that they tried to analyze, okay, what are we missing in the current practice? So what did they do? They took the inpatient, they took the COPD patients who have been admitted for COPD exacerbation into the medical ward and died in the first 24 hours of their admittance. And they autopsied them and tried to understand what did they miss. And it is really interesting that these 37 patients who died in 24 hours of admittance found out to have heart failure, 28% had pneumonia, 21% had pulmonary embolism, and only 14% has only COPD and nothing else. So these three are the most commonly missed ones. So as we mentioned, and this is, of course, pulmonary embolism is the most dangerous one. So heart failure, pneumonia, and pulmonary embolism. We should really give a big importance in our differential list, mostly because it is really small and we can eliminate them really easily and really straightforward. Therefore, we should give a good importance to it. So thanks for listening. Today, I was Dr. DrSotalol, and we are going to talk about treatment and the management of COPD exacerbations in the next video. Thanks.